Good morning, everyone. Thank you so much for joining today's webinar. We are going to give it a few moments for guests to join, and we will be getting started momentarily. All right, well, welcome everyone, and thank you for attending today's webinar, Guardrails Against Medicaid Fraud, Waste, and Abuse, a presentation for New Jersey adult medical daycare providers. I'm Melanie Donnelly, and I'm an administrative analyst in the New Jersey Office of the State Comptroller Medicaid Fraud Division. And today's training is specifically tailored for adult medical daycare providers who provide services to New Jersey Medicaid beneficiaries. Today's presentation will be recorded, and after the presentation, the slides you're about to see will be shared with you through email and also posted on the Office of the State Comptroller's website. So we are presenting to you today in partnership with a number of New Jersey state agencies and key stakeholders of the New Jersey Medicaid program. And that includes the Office of the State Comptroller Medicaid Fraud Division, which is the agency that I'm a part of, the Department of Human Services Division of Medical Assistance and Health Services, which is also called DMAS, the New Jersey Medicaid Managed Care Organizations, the Department of Health, and the Office of the Insurance Fraud Prosecutor's Medicaid Fraud Control Unit. So you will have an opportunity to hear from representatives from all of these areas today. And before we begin, we just want to thank those of you who are enrolled as a provider in the New Jersey Medicaid program and who provide services to beneficiaries here in New Jersey. It is so important that they have access to good quality care, and we thank you for that. Just a little bit of housekeeping before we dig in. The presentation you're about to see is intended for general educational purposes only. It does not replace your responsibility to seek professional guidance and observe all the laws and regulations that pertain to your practice as a Medicaid provider and exercise professional judgment. A couple of our goals for today are to help all of you better understand the Medicaid program's regulatory oversight structure and compliance requirements with AMDC services, the Medicaid documentation requirements for payment, fraud, waste, and abuse obligations of providers, and any red flag areas and the consequences for noncompliance. If you have questions today, please put them in the Q&A. We probably are not going to have time to answer questions live because of the amount of content we're trying to cover, but we will take all of the questions back and we'll respond to them in writing at a later date. So if something is on your mind, let us know. If you choose to post a question anonymously, that's okay. But if you are able to attach your email, we will have reassurance that we will be able to get you the answer that to the question that you've asked. So now that the housekeeping items are out of the way, we're going to get started. We're going to start briefly by talking about what is Medicaid. Medicaid is a jointly funded federal and state program. It provides funding for medical costs and specialized services for eligible individuals. And participation in this program is voluntary. But if you want to participate, you need to know and accept the rules and regulations. And participation on an ongoing basis does require compliance with regulatory requirements. And throughout this presentation, you might hear the words Medicaid or New Jersey Family Care used interchangeably. New Jersey Family Care is the name of the Medicaid program in the state of New Jersey. This slide provides an overview of the New Jersey state agencies and related entities involved in overseeing the Medicaid program, specific to adult medical daycare providers. So starting on the left, the Department of Law and Public Safety houses the Medicaid Fraud Control Unit, and that's the criminal arm of Medicaid oversight. And next, you'll see the Department of Human Services, which encompasses the Division of Medical Assistance and Health Services. DMAS holds the contract with the Medicaid managed care organizations, which you also see on the slide. And also included is the Monmouth Medical Assistance Customer Center, and that's the entity that's responsible for fee-for-service adult medical daycare services in certain scenarios. Next, you'll see the Office of the State Comptroller, and that's an independent state agency that you might not be as familiar with. Within the Office of the State Comptroller is the Medicaid Fraud Division, and that's the area that I represent, and that's the civil arm of Medicaid oversight. And last but not least, the Department of Health, which includes facility licensing, surveys, and inspections. And you're going to have an opportunity to learn more about all of these areas throughout the course of this presentation. The next several slides are intended to provide an overview of the size and scope of Medicaid adult medical daycare services here in New Jersey. So the chart that you see on the left is the total Medicaid spending on adult medical daycare services between January 2019 and September of 2024. And what you'll see is that the overall spending in this area has decreased, whereas the chart on the right shows the number of Medicaid beneficiaries receiving these services during that same time period. So while spending on the left has decreased, the number of beneficiaries receiving services has remained pretty steady. This slide represents the fee-for-service spending as compared to managed care spending for the same time period on the previous slide. So only about 0.1% of the services, adult medical daycare services, are in the fee-for-service space, which you'll see on the left. And on the right is the Medicaid managed care spending, which is the vast majority for this population. And finally, this slide shows how the adult medical daycare services are shared among the managed care organizations, with Fidelis Care having the largest portion of the pie and Aetna having the smallest during that same time period. So it's just interesting to see how that's broken out among the five managed care organizations here in our state. And I'm going to turn things over now to Geraldine Molinari, who's the Director of Managed Care Provider Relations at DMAS.
Good morning. So what I'm going to go through is some regulations and where you gather the information specifically from the Division of Medical Assistance and Health Services regarding medical day. So if we go to the next slide, just to reinforce the Division of Medical Assistance and Health Services, we are part of the Department of Human Services, and we are responsible for administering the Medicaid program and making sure that state and federal guidelines are incorporated into our contracts when we work with the individual health plans. And as mentioned previously, Medicaid is a program for individuals who qualify based on medical need and income. So this website, the njmmis.com, is critical for any Medicaid provider. This is a place where you will access newsletters regarding services. It's also, as identified here, where you would find the regulations regarding adult medical day and the prior authorization requirements for these services. If we go to the next slide, the Medicaid newsletters are also identified here. I'm sorry, can we go back to, if you, along the left side of this screen, if you would scroll down a little further in this this design, there's a option for newsletters. And then you can always search based on year or a topic to find the newsletters. So if we go to the next slide, the Medicaid newsletters introduce programs or services. We also publish newsletters when there's updates or updated program guidance, and they can always be found on www.njms.com. And again, you can search by provider type and subject. Sometimes if you don't pick the right subject, my suggestion is you go by year to look. There's not that many newsletters. You can just look and make sure that you're finding seeing all the information that may be available in the newsletters. Next slide. One of the critical pieces for providers before you start to do anything with Medicaid, with the managed care organizations, is registering. And this is a new regulation, new in 2018, but it requires that all providers, whether they're going to do services fee-for-service or enroll with the MCOs, that they have to submit a 21st Century Cures application to Gainwell Technologies, who manages the DMOS side of enrollment for fee-for-service. So a provider must complete this application before they even go and try to contract with the individual MCOs, as the MCOs will always be looking for confirmation that the 21st Century Cure application was submitted. So in order to get the application, you go again to the njms.com site, select provider enrollment applications, and you would then select the 21st Century Cures application. And questions regarding this aspect of a provider enrollment are addressed to Gainwell Technologies. After you complete this section of enrollment, you would then go to the individual MCOs for credentialing and contracting questions. Next slide. So many of you are probably already familiar. We have 5 contracted managed care organizations: Aetna Better Health in New Jersey, WellPoint, who was formerly AmeriGroup of New Jersey, Horizon NJ Health, United Healthcare Community Plan, and Fidelis Care, which was formerly WellCare Health Plans of New Jersey. So in the last 18 months, AmeriGroup, or WellPoint, and Fidelis have taken on new names, same structure, same contract. They just updated their tags, and so you would be continuing to work with each of the 5 plans if you're interested in contracting with each of them. Or as a provider, you can select to just pick one plan or 2 plans. One point is the plans have network requirements. So once they've filled their network requirements and they feel like they're able to meet the needs of their enrolled members, they're not always accepting new providers for adult day. So that's just a point of information that you should be familiar with. It's not like fee-for-service. Once you want to enroll, you can enroll. With the managed care organizations, they meet contract requirements, and then they may decide whether or not they need to grow their network. And I'm going to turn it over to Michael, who's from the Department of Health, who's going to go through Michael Kennedy. Thank you.
Thank you very much. I'm Michael Kennedy, the Executive Director of Certificate of Need and Licensing at the Department of Health. Our office is responsible for the licensure of all healthcare facilities in the state of New Jersey. Obviously, adult day health services are one of those facility types that we license. And you'll see on the next slide that we have administrative rules and the New Jersey Administrative Code that are specific to this facility type. NJAC 843 are the standards for licensure of adult day health service facilities. Later, I will give you a citation to another regulation that everyone should be aware of because it pertains to all facility types. Now, the Medicaid rules for adult day health services are not under the Department of Health's chapters in the Administrative Code. They are found at NJAC 10:164. Next slide, please. Thanks. Probably as you know, that adult day health service facility means a facility or distinct part of a facility which is licensed by the department to provide preventative, diagnostic, therapeutic, and rehabilitative services under medical and nursing supervision to meet the needs of functionally impaired adult participants who are not related to the members of the governing body by marriage, blood, or adoption. Adult day health service facilities provide services to participants for a period of time that does not exceed 12 hours during any calendar day. The beginning steps to establishing an adult day health service facility is that you must first submit to the department, to my office, a detailed project narrative. And this application, this project narrative form, which we call the CN6, is available online at the link there. Now, the project narrative, it's very important that it includes all information as to what the applicant is seeking, what services you're going to establish, how many slots you wish to have, the location where they'll be provided, and it must be signed by the applicant, not your architectural firm. And that's we referenced the architectural firm because if it's a new construction or if there's going to be renovation to an existing facility, you'll see in the upcoming slides what needs to be done for that. Next slide. The project narrative in CN6 shall be submitted along with full-size and scaled architectural plans. The plans must comply with the physical plant requirements found in NJAC 843F. The applicant must read, understand, and comply with the standards of licensure of adult day health services found at that chapter. And it's important because you're going to test that you are aware of these rules and you're going to comply with them at all time. And the other website or the other, administrative code section that I referenced that you should be familiar with is found at 843E. It's the general licensure procedures and standards applicable to all licensed healthcare facilities. In that, there's a link there to the New Jersey Administrative Code where you can find not only our chapters, but all chapters of the Administrative Code. And I believe that's a free link. But 843E is important because that's where you're also, there are a lot of things in there that apply to facilities that may be out of what maybe your comfort zone or what you're familiar with. As being provided under 843F, but that's also where the penalty actions are found. So that's where if there's a survey and you're assessed a penalty, it's under the authority of a subchapter of 843E. Schematic drawings have to be submitted via hard copy. Now we're trying to go, paperless for most things, but architectural drawings have to be submitted via hard copy to the address that you see here on the slide. Sort of the flow chart here from left to right is that you submit the project narrative, CN6 form, and architectural plans. We have architects here in the department in our office who will see if the physical plan meets the requirements at 843F and also the Facility Institute guidelines, the FGI guidelines, which some of you may be familiar with. Now, at that point, once you get our imprimatur and our stamp of approval, the department will issue a letter that authorizes you to proceed to the Department of Community Affairs Healthcare Plan Review Unit. It's important for everyone to realize that our architects and the folks at DCA are looking at two different things. We're looking at our administrative rules and the FGI guidelines. DCA folks are looking more towards fire safety, things of that nature. Now, after the construction or a renovation project has begun, and you think that you're within 120 days of receiving your CO, you should submit your licensure application form, the LCS-9, which is found at that website. The first step in the process is you have a project description for your new facility. You get our blessing, you get DCA's blessing, you begin with the contracting. Now you submit the LCS 9 form, which must be completed in its entirety and include a detailed cover letter and again, project narrative with the requisite fees that you see here. And this is the step to get your actual license. Again, like I referenced before, we're trying to go paperless. So we give you the option to pay via ePay or by check. ePay is a lot easier. And if there's any issues or questions you have about ePay, if you contact the department for the analyst for your county. It's also important to note that we divide up responsibility among our analysts by county, not by service type. So whatever county you're located in, the analyst responsible for your county will be responsible for all or have assigned to them all healthcare facilities in that area. And again, the application, if it's going to be submitted via hard copy, that's the address there. But the easiest way, the best way for tracking, you'll see is to send it to cnlapps@doh.nj.gov. And if you're leasing space, a copy of the lease must be provided. We do encounter situations where facilities run into disagreements, arguments with their landlords. It's always good to keep us apprised of any situations that can be coming up even after the initial license, but you have to show at the outset that you're really going to be permitted to be there. You're also, as I indicated previously, you're going to have to attest that you will comply with the rules found at 843F. You're going to be attesting that you've read them, you understand them, and you're in compliance with them. I would strongly recommend to everyone that you have a copy of 843F and 843E handy at your facility at all times. Your application form must identify 100% of the ownership. Separate ownership chart may be provided, which will outline 100% ownership of the facility at each ownership level. This is very helpful because we're finding with all sorts of facility transactions or formation, I guess I should say, is that there are many levels of ownership now. There are trusts involved. Over the course of my career, I've seen them get much more complicated. Just in terms of structure, and for whatever reason, good or bad, that's where we are. But we do need to see 100% of the ownership from top to bottom. If you own, manage, or operate any out-of-state facilities, you have to provide a track record for each of the for each facility from the out-of-state licensing entity. So if you're in Pennsylvania, you're going to have to provide us with a track record review. And the track record review, just so we're clear, is a review of your your inspection surveys, any penalties that you may have had at an out-of-state facility. Obviously, in-state, we will check that with our survey folks. But the out-of-state, you're responsible for getting information from the licensing agency in the foreign state. If any applicants own more than 10% of the ownership or stock in the facility, and you also manage out-of-state facilities, you can contact the department, again, the analyst for your county, for forms to be completed to attest to track record compliance if you're unable to get cooperation from the out-of-state licensing entities. I mean, we understand that we've encountered this a lot with all of our facility types when we're like, hey, Indiana just won't get back to us, or Pennsylvania won't, New York won't. If you show a good faith effort and that you tried to reach out to these folks, those agencies, we will permit you to perform an attestation, to fill out an attestation, I should say, attesting to your out-of-state track record. A copy of the CO issued by the local authority and a copy of the DCA releases and the CBI clearances, that's the criminal background investigation clearances for all owners and administrators must be provided with the application. And you also have to advise the anticipated date the facility will be patient ready to open and operate. Next slide, please. Yeah, that last point of being patient ready is really important because that's when your survey is going to take place. So once the application is completed and the facility is ready to open, my office will send it literally downstairs because they're below us to the survey group for the review and scheduling of the initial on-site survey. The survey will provide, when the survey is complete, and again, you have to be patient ready for the survey. That means you have everything up. You're just ready to start. The survey team will provide us with their recommendation, and if approval is recommended, you will get a verbal approval. Someone will call you or email you and follow up with an email saying that you're ready to go, and then you will get a final letter and initial license about 6 weeks after receiving verbal approval. But just so we're clear, that's why it's important to be patient ready for your survey, because we're going to call you up and say, you can start, and you can start as of that moment. Obviously it'd be like the next day or the couple days afterwards, probably, till you got people in. But one things that we encounter with facilities is where they attest that they're, or they aver that they're patient ready. Survey goes out and they have to abort the survey because they're not ready. And some of them are pretty egregious. I don't know what the thought process is by some of these folks who aren't ready to go at all. I think whatever their reason is, but you need to realize that drops you further back in the queue, not out of punishment or out of spite. It's just that we're very busy. We got a lot of facilities, and if you're not ready when survey goes out, it could take a couple of weeks for them to find time in their schedule to go back out again. Following initial licensure, if you propose any changes to your physical plan, slots, shifts that are offered, or other required services, or you want to transfer ownership, you're strongly encouraged to contact the department for guidance. We will hook you up with the analyst for your county, who will be able to walk you through the process. And you see the number there where you can call to find out who the analyst is for your county. A lot of times you see if you have a few projects that have gone underway, you may already have a relationship with your analyst. They may have done your initial licensure. They may have worked with you on some projects. But if you do need to find out who it is, call that number. It's really also important that you realize that before you undertake any renovation project that's not merely cosmetic, you have to get approval by the department. So it goes back to the beginning of my presentation when we referred to the CN6. It's the initial project application or renovation form. What we need to find out is that, we need to know is that if you've significantly renovated your facility, that it still complies with the FGI guidelines. So you're strongly encouraged before you, and some of the times, honestly, one time we had a nursing home that moved an entire nursing station, and they said that was cosmetic. So I bring that up only to say, don't stretch the boundaries of what the definition of the word cosmetic is. If you have any questions, contact your analyst. Licensure renewal. License are valid for 1 year plus a 30-day grace period. You really don't want to be in the grace period, because that's when things get a little desperate. And we currently have 2 adult medical daycares that are in the grace period. So, and it's kind of hard, if don't know how it happens, because we send, like you see, a first reminder 90 days out, second 60 days out, third reminder 30 days out, and the fourth reminder is that you're gonna get phone calls. And once you get into the grace period, you're gonna have a lot of, sometimes it gets down to the wire, and it really doesn't need to be. I would encourage everyone to monitor their generic emails. We do have one of the things that we find, if there's a licensing issue, the owner may say, well, gee, I had an administrator here and he or she left and they took care of this for years, it's really not a delegable duty. I mean, you have to make sure that your license is, I mean, go look at it. You know, it should be hanging on the wall and has an expiration date. If the license is not renewed by the end of the grace period, intake will notify the facility that an enforcement action alert will be sent to our Office of Program Compliance with a recommendation for an order to cease and desist operations. It's different than a summary suspension, which some of you may have encountered or heard of. A summary suspension of a license is when you have an existing license, but survey finds that there's jeopardy at the facility, which is putting participants at risk, and your license would be summarily suspended. If you don't have a license, you get an order to cease and desist. The only way you can challenge that is in the New Jersey Superior Court. And you also have to know that the cease and desist is public. It's posted on the website. It's shared with other agencies, and we do get a lot of incoming from different payer sources about facilities licenses. So, you know, please don't get yourself to the point where you're in the grace period or you're running up against a cease and desist being issued against you. It's also important if you decide to surrender your license, if you decide to close, Rule NJAC 8:43F-2.7 requires that you notify each participant, the physicians, APNs, PAs, or any guarantors of payment at least 30 days prior to the voluntary surrender of a license, or closure is another term. Or if it's directed under order of revocation, it's the same situation. In any event, if you're going to shut down for any reason, you have to give us and the participants and those other folks at least 30 days notice. And with that, I'm going to turn the presentation over to Ashley Scott, who's the Senior Manager, Network Relations at Aetna Better Health of New Jersey.
Thank you so much, Michael. Good morning. This is Ashley Scott with Aetna Better Health of New Jersey. I will be reviewing the requirements to participate with the MCOs. Participating with the MCO will allow your agency to provide services to eligible New Jersey Medicaid members enrolled with the plan. You'll go through two main parts of the process, which is provider credentialing and provider contracts. Provider credentialing. Credentialing is the way the MCOs can verify that your agency has all the required documentation to participate. It ensures quality, compliance, and accountability. Credentialing requirements includes the credentialing application, detailed application form to collect the necessary information, your license, the proof of valid and current professional license, the approval letter from DOH, liability insurance, your tax ID or your W-9 form, the NPI, which is unique for all healthcare providers, certificate of incorporation, your INC, I'm sorry, and business registration certificate, your proof of business registration. Provider contracts. The contract makes your agency a participating provider with the MCO, allowing you to provide service to eligible MCO New Jersey Medicaid members that qualify for adult day health services. The contract is prepared by the MCO and sent to the agency. The agency will then review that contract term and sign. And then the MCO will return the countersigned form with the final signature. Once the entire credentialing package, including the signed contract, is complete, it is submitted to the MCO credentialing department for processing. The credentialing process can take approximately 60 to 90 days for completion, but you will need to consult with the specific MCO for their timelines. I will now be handing the presentation over to Mark Fernandez, Provider Relations Manager with United Health Group.
Good morning. I'm Mark Fernandez with United Healthcare of New Jersey, and I'm going to talk to you about background check requirements. So for background check requirements, providers must submit a criminal background check along with an attestation as part of the credentialing process. There are no exceptions. You must comply with NJSA 451-3, which requires a criminal background check for every person with a license or certificate as a healthcare professional. Policies and procedures that show compliance with the state requirements to have a pre-employment criminal history check and/or background investigation on all staff members. Nursing facilities should perform background checks based on CMS survey requirements. The ownership requirements. We require a completed application, a license as appropriate for the service being contracted, proof of DOH of NJ Adult Day Health License. A site visit is required only if there's not a Medicaid certification or accreditation by an approved entity. Meet qualifications as outlined in the credentialing plan under CMS and NCQA. Monthly verification that agency or employees have not been excluded from Medicare or Medicaid participation. Evidence of compliance with all applicable laws and regulations, including workmen's compensation and unemployment insurance and general liability insurance. For agency employees, no felonies or listings on abuse and sex offender registries, documentation of verifying financial capacity to operate, documented service delivery assurances, compliance with HIPAA requirement, accurate completion of a disclosure of ownership and control interest statement and disclosure of ownership information at any time upon request, a submission of a substitute W-9 form, a signed attestation for the accuracy and completion of all required forms, an assignment of valid Medicaid number, and standards assessment and documentation review. I just want to add for each provider, each payer might have a different process. So I'd ask that you contact your point of contact at the payer. Ownership requirements. Notify the MCO in writing following the timeline outlined in your provider contract if any following events have happened: bankruptcy or insolvency, indictment, arrest, felony conviction, or any criminal charge related to your practice or profession, suspension, exclusion, debarment, or any sanction from the state or federally funded healthcare program, the loss of suspension of your license to practice, departure from your practice. And again, reach out to your point of contact if necessary. For a change of ownership, known as a CHOW, this typically occurs when a Medicaid provider has been purchased or leased by another organization, results in the transfer of the previous owner's Medicaid identification number and provider agreement, including the previous owner's outstanding Medicaid debts, to the new owner. You may notify the MCO following the timelines outlined in your provider contract if you are acquired by, merge with, or decide to transfer some of all of your assets to another entity. And again, please reach out directly to your MCO point of contact if there's nuances in your contract regarding this issue. And I will now turn it over to William Keller for fee-for-service and eligibility authorization. Thank you.
Good morning, everybody. William Keller here. When a Medicaid member is receiving payment by the fee-for-service Medicaid program. You'll be submitting prior authorizations to me. So eligibility for authorization includes clinical eligibility and prior authorization for adult day health services. The regulations can be found under the New Jersey Administrative Code 10:164-1.5. There's also a Medicaid newsletter, fee-for-service prior authorization clarification, volume 29, number 5. Prior authorization for fee-for-service adult day health is handled by Division of Medical Assistance and Health Services under the following scenarios. When a Medicaid beneficiary is newly enrolled and in waiting enrollment in managed care, or there has been a gap in their managed care enrollment. Retroactive prior authorizations must meet the following criteria. They've been referred for PA no later than 90 days after the managed care disenrollment has happened. A valid managed care authorization was produced or exists at the time of the managed care disenrollment, and there was no break in Medicaid eligibility. Fee-for-service authorization in both these cases can be made for up to 90 days. Only New Jersey Family Care Certified Adult Day Health Service providers can submit prior authorization documents for temporary fee-for-service coverage for clinically eligible individuals. The Adult Day Health Services provider is responsible for submitting the following documents to receive authorization. Prior Authorization Form FD-411, that's the Prior Authorization Request Form. You also include one of the following attachments: a physician certification. That form is called the PA4A. That's completed by the member's doctor, and that doctor will certify that they meet the clinic eligibility requirements for adult medical daycare services. You can also submit or submit a New Jersey Department of Human Services Division of Aging Services Office of Community Choice Options approval letter for medical daycare services, or a prior produced managed care authorization for the same service. Like I said earlier, all fee-for-service prior authorization requests will be coming to me, and you can submit any and all documents that you need to receive that authorization. Please assure that all required fields on the prior authorization request form are completed. Otherwise, I have to send it back to you and I'll highlight the omitted fields. You can get them to me by faxing them at 732-863-4450, by mailing them to the Monmouth Medical Assistance Customer Center at 100 Daniels Way, Freehold, New Jersey, 07728, or you can email me. There's my email address, william.keller@dhs.nj.gov. Now, if you're going to email prior authorization requests and documents, remember this is all personal health information. The HIPAA security rule requires that these documents are sent via encrypted email. You just can't send it over standard email. If I receive documents that are not, or emails including personal health information that hasn't been encrypted, I'm going to be deleting it and just sending it back a garden variety message that I can't accept the document. Please send it by fax or mail. And with that, I introduce Kate Andujar, and she represents United Healthcare. She'll be talking to you about eligibility.
Good morning, everyone. My name is Kate Andujar. I'm going to be reviewing the Adult Day Health Service benefit and member eligibility and ineligibility. Next slide. So this service is an alternative to total institutionalization for those members who are eligible and can benefit from Adult Day Health Services. Adult day health services provide medically necessary services in an ambulatory care setting to individuals who are non-residents of the facility. And due to physical or cognitive impairments, they require such services to be supportive to their community living. The program can be accessed by the members up to 5 days a week for a minimum of 5 hours per day. And this excludes transportation. Transportation to and from the program is provided, and it cannot exceed more than 1 hour each way. Clinical eligibility and prior authorizations for adult day health services. So the members must be determined eligible for Medicaid. They must meet clinical eligibility requirements using the New Jersey Choice Assessment that's completed by the MCO staff that's done in person. Once the MCO completes the assessment, if the member meets clinical eligibility requirements, they will send the medical daycare an authorization for that member to start attending. Redetermination of eligibility will occur at least annually, and it can occur more frequently if there's a change in condition for that member, and someone from the MCO will go out and reassess. Next slide. Continuing eligibility for medical daycare. The member must have at least limited assistance in a minimum of 2 activities of daily living, and the facility will provide all the assistance for the claimed ADLs on site in the facility. They could have at least 1 skilled service provided daily on site in the facility. They may require supervision and queuing in at least 3 activities of daily living, and the facility will provide all that supervision and queuing for the claimed ADLs on site in the facility, and as determined, as identified by the assessment that we use that's prescribed by the department. The individual exhibits problems with short-term memory, following multitask sequences, and in daily decision-making in new situations. Next slide. So for a member to be ineligible for medical daycare, so adult day health services will no longer be covered for members who fail to attend approved services for 1 month. So 30 consecutive days of non-attendance. So for them to re-enter the medical daycare, they will require a new assessment and authorization. The individual is receiving services that are duplicative or redundant. So for example, if they're getting PCA services at home for bathing assistance, and bathing is one of the ADLs that's being considered for one of the 2 ADLs for adult day health services, and not being provided at the facility, if there's a duplication, they would not be approved for that. The individual resides in a residential health care or an assisted living facility. The individual is receiving inpatient hospital or nursing facility care, or the members receiving rehabilitative therapies and or medication administration are the only services that the individual will be receiving, and there's no other criteria present, so they would not be able to attend. Next will be Colette Conroy and Carol Cianfrone from Horizon discussing Medicaid documentation requirements for payment.
Good morning, it's Carol Cianfrone. I will be presenting the slides on the documentation requirements for payment. So, again, we'll address documentation, billing guidelines, review of discharge criteria and authorization requirements, as well as record retention requirements. You can go ahead. So when a member is admitted to a medical daycare, the expectation of the facility is that they are providing or completing an initial assessment on that first day of admission. And that needs to include their hygiene needs, dietary needs, medication ambulation, or anything specific to that member. And then a written initial plan of care shall be developed within 5 business days of the date of that assessment. They must have a doctor's order to attend medical daycare, and that order must also include what the needs are of the member, right? The nursing, dietary, social work activities, those type of things. You can move on. So the comprehensive assessment, right? So the initial assessment is just a very overview of the member. A very comprehensive assessment shall be completed within the 14 days of that first attendance, and that comprehensive assessment shall include at a minimum the evaluation of all of these areas. So their physical functioning, their medical conditions, their skin condition, all of those need to be included in that full comprehensive assessment. So once that comprehensive assessment is completed, the expectation is that an interdisciplinary plan of care is completed, and it's based on that initial and that comprehensive assessment. It must include the member's scheduled days of attendance, the goals of care for that member, the participant's needs and preferences. Members have a right to preferences, and we need to make sure that's included in their plan of care. The orders for the treatment services, medication, and diet, and the time intervals at which the member's response to those treatments will be reviewed. So each area of that plan of care needs to say when you're going to reevaluate that part of that plan of care to ensure if any changes need to be made, they are made, and the plan of care is updated, and or if that goal has been met, that those goals are closed, and any new goals that may be needed are added to that plan of care. So again, it should be based on the comprehensive assessments and include all of those areas such as nursing, dietary activities, social work, the orders by the physician or that other health professional, consultation with pharmacy, and it shall also have measurable goals, right? So the plan of care should have measurable goals and interventions based on that member's plan of care, and how you are planning to assist that member to reach that goal. So if the goal is to increase medication compliance, what the expectation of the interventions are is not only having them increase their medication compliance while they're at the facility, but what is being done to ensure that that member's medication compliance is being carried through when they're not at the facility and when they're home, either on weekends or evenings or mornings, to make sure that they're compliant with their medication regime. So again, that's the expectation of all of the goals, and making sure that each goal has those measurable objectives and interventions. It should include any rehabilitative or restorative measures that are needed for that member, even habilitative. So if a member is having difficulty walking, we should ensure that that member is on a habilitative program while at the facility to help them to strengthen and maintain that ability to ambulate and not decline because they're not getting some assistance in those measures. And again, teaching self-care and teaching how to maintain those goals and that plan of care services when they are not at the facility. As said before, there shall be a scheduled review and evaluation of each section, and that should include the evaluation by the physicians and or who the nurse practitioner or physician assistant that originally ordered the treatment. They should be performed as necessary, as well as at least quarterly for every participant. So medical records. So these are your EMRs or even paper, the medical records of that member that's in attendance. It is required to include all of the following, as well as anything else that may have occurred or is part of their treatment plan in the facility. So it needs to have their demographics, name, date of admission, address, birth date, rate, emergency contact. All of that needs to be part of their permanent medical record. The participant signed acknowledgement that the authorized representative has the ability to speak with and to interact with the facility. Needs to have the participant's rights and responsibilities. There needs to be an assessment of the participant's home environment. The expectation is that the medical daycare is going into the home and doing an evaluation of that home setting. A summary of their admission interview needs to be part of that medical record. You can go on. All of the assessments developed by each provider that is seeing that member or participant. The plan of care needs to be part of the medical record. Clinical notes, any notes that are entered as part of this member's record, they should be entered on the day the service is rendered, and that should be maintained in the medical record. Progress notes, so summaries of the progress that the members made need to be part of the record as well. MARS, medication administration records, need to be part of the permanent record, and it needs to include the who administered it, what date, what time, how it was administered, and the signature of the person that administered that medication. If the member is self-administering medications, that still needs to be part of that medical record. You need to make sure that you're documenting that you have ensured that the member is accurate with their self-administration, that they understand the need to be compliant with their self-administration, and that needs to be an ongoing review with the member to make sure the member can manage that and continues to manage it appropriately. Documentation of any allergies, both in the medical record and on the outside front cover of that medical record. So it's evident for anybody that picks up that chart if there's any allergies. Documentation of other services for that member, such as dental, laboratory, and radiology services that were provided. Referrals to other healthcare providers, documentation of those consultations, and any written informed consents that were part of the member's treatment at the facility. Any advance directive or living will that the member has should be part of their medical record and should be available to anybody treating that member. A record of any treatment medications offered and refused by the member in the facility. So if the member is supposed to be getting medication daily and every time we go to give it, or even once that you go to give that medication and they're refusing, that needs to be documented and the reason why that participant is refusing. All orders that were given for any treatment or any services to that member in that facility when they're at the daycare needs to be part of that medical record. And it could be verbal orders, but those verbal orders need to have the actual ordering physician or physician assistant, nurse practitioner signature, and therapies. All of that needs to be part of that medical record. An attendance listing for that member, for what days that member actually was in the facility and attending the program. A photograph of the participant, and we need to make sure that we're keeping those photographs up to date. If somebody's been attending for several years and there's been a significant change in the way they look, we should ensure that we have updated photographs as part of that medical record. And there also should be a discharge summary in accordance to the regulations as part of that record if the member has been discharged. So for billing guidelines, when we move on to billing, so it is a per diem rate set by, minimum rate is set by the NJAC. Each MCO may choose to decide to contract for different rates, but there is a minimum set rate that we cannot go under. They are required to have the condition of licensure. So you have to be licensed in order to bill for the services. They all need to meet that clinical eligibility and have an authorization for those services to be paid. And they must attend the program for at least 5 hours a day, excluding transportation time. So, and they should not exceed more than 5 days a week. Transportation time may not exceed 1 hour each way. So they can drive 1 hour there, 1 hour home, but it can't exceed that 1 hour. And that time does not get included in their minimum of 5 days of attendance or 5 hours of attendance a day. Sorry about that. So the adult medical daycare facilities are expected to provide transportation to and from medical appointments if that member needs that transportation. But those appointment time, so if the member comes to the medical daycare at 9 o'clock in the morning and they have a 10 o'clock appointment at a doctor's office and the medical daycare brings them to that doctor's visit, and they're there at the doctor's office for an hour, that hour and that transportation there and back does get included in that 5 hour minimum that they need to be there at the adult daycare for the day. So again, it needs to be pursuant to the include transportation to and from the facility as stated, and not the transportation just to the medical daycare and home from that medical daycare. That is exempt from the time that they were at the appointment. The facility shall accommodate any special transportation needs of the beneficiary and any medical equipment needed for that beneficiary. So discharge criteria and authorization requirements. So authorization, if we look at it, right, there should be discharge planning starting at the day of admission, right? It's no different than any other facility or any other program. The expectation is that the members are attending and they may improve and may meet criteria to be discharged. The expectation is not that it's ongoing, continuous if the member improves. The discharge plans must be in compliance with the regulatory requirements, including Medicaid eligibility if applicable. So if a member, there needs to be a plan in place if that member loses Medicaid eligibility. What is the discharge plan going to be, and how are the member's needs going to be met upon discharge? So the facility and the participant, as well as the caregivers or family members, should work to identify those alternate resources if that member is loses Medicaid eligibility or no longer meets the criteria to attend medical daycare, to ensure that those members' needs are being met. And again, the family members, caregivers should all be part of that planning for discharge. You shall ensure that you are maintaining as part of their medical record as well that signed attestation by the facility, by the member or the member's authorized representative, that they have been provided with written explanation of the policies and procedures regarding discharge, and that they agree or disagree with it. Just because they disagree with it does not mean that they should not be discharged if discharge is appropriate. So when there is a change of status in the facility documentation in the plan of care, that may alter the member's eligibility to receive a medical daycare. So again, as I said, if a member improves, right, if a member's there for uncontrolled hypertension and that hypertension has now been brought under control due to the interventions done at the facility or even outside of the facility, that member may not continue to meet criteria to attend that medical daycare. Again, that needs to be documented in the plan of care and should be part of that discharge planning and part of the goal to get that member discharged without attending the medical daycare but remaining stable. Records retention. So the expectation is that the medical daycares are protecting medical records against loss, destruction, or unauthorized use or ability to see them for members for a period of 10 years following the last discharge date or the last attended date of that participant. The summary receipt shall be retained for a period of 20 years. Any X-ray films or reproduction shall be retained for a minimum period of 5 years. So the expectation of the facility is that you are maintaining these records in a secure location, whether on paper or in a medical, in electronic medical records, but that you are keeping them at a minimum of 10 years and a summary for a minimum of 20 years. The facility shall develop policies in regards to the timeframes of medical record retention and what the disciplinary action would be for people that are not compliant with that policy. So there should be a procedure for transfer of participants if the member chooses to not attend that daycare anymore and move to a different daycare. Maybe they moved and it's not convenient or not within that hour any longer, or maybe they're just not happy and want to attend a different daycare. There needs to be a procedure to transfer that member and all the information that that medical daycare has to the new facility that's managing that member. And as before, the facilities are required to give the department notice at least 30 days in writing and members 30 days in writing if they're ceasing operation. And they also need to provide the department with the location of where those medical records for those treatments that had been provided will be stored and how they can be retrieved. So if a medical daycare is closing, they still are required to maintain those records and keep them secure, and they must notify the department in writing where those medical records will be stored. I will be turning it over now to Tracy Livingston for compliance and Medicaid fraud.
Good morning, everybody. Thank you very much. So let's get started. The Medicaid Fraud Division. The Medicaid Fraud Division was established by the Medicaid Program Integrity Protection Act. And this which established the Office of the Medicaid Inspector General to detect, prevent, investigate Medicaid fraud, abuse, recovery, improperly expended Medicaid funds, and enforce Medicaid rules and regulations, audit cost reports and claims, and review the quality of care given to Medicaid recipients. These functions, powers, and duties were later transferred to the Office of State Comptroller and are carried out by the Medicaid Fraud Division, or MFD. Program Integrity Oversight. So this refers to the system of monitoring audited facilities that provide adult day health services to ensure that they are billing Medicaid accurately, delivering the appropriate care, and also are not engaging in fraudulent activities. Medicaid oversight functions, program integrity oversight. So here's a few things also that we do. We enforce Medicaid rules and regulations. We audit and investigate potential fraud, waste, and abuse for providers and for recipients. We recover improperly expended Medicaid funds. And we also coordinate PI oversight efforts among state agencies that provide and administer Medicaid services and programs. This part here is really important, and this presentation is an example of that. One of the things that we all try to do over the last couple of years is make sure that we coordinate our efforts better. We want to make sure so that if the Medicaid Fraud Division hears something that maybe has to go over to the Department of Health or some other one of our state agencies, we're doing that a lot better today. And this is an example of that. So we want to make sure that we get all the players in the room so we can make sure that we're all working together. Another thing that we also do, we exclude or terminate providers from the Medicaid program when necessary. This is another really important function that we do because, simply put, if we have a bad provider in the program, one, you're talking about patient safety, you're talking about low quality of care, and it also impacts the actual reimbursement that can be dispersed to all the providers. So essentially, if you have a provider who is siphoning money from the Medicaid program, that hurts all of you. So that's why it's a really important function that we also do as well. Why is the program integrity oversight important? Again, to protect the Medicaid funds, to help ensure that the Medicaid dollars are used effectively to provide quality of care to individuals. This here is also another thing that I also wanted to point out, the quality of care. Our office is known probably for recovering funds and making sure that we look for waste and abuse. But another thing that we do in this presentation is example that is quality of care is important to us. We also want to make sure that the services that are provided to the recipients, they're getting the services that they're supposed to. We also want to make sure that there's no abuse in these agencies, and that's something also that we make sure that we monitor as well. So I just wanted to say that that's something that we really take seriously. Another thing you'll see towards the end of this presentation, we're going to talk to you about how can you report fraud, waste, and abuse. That's really important because let's say if you report something to our office and from that we see that complaint or tip deals with quality of care, we will immediately share that with our sister agencies to make sure that problem is resolved. So that's an example of how we work together. Again, maintaining quality of care, it helps to ensure that the adult day health services facilities are delivering appropriate and necessary care to patients. Consequences. Non-compliance with Medicaid rules, standards, and regulations regarding services may constitute acts of fraud, waste, or abuse in Medicaid funds. This slide is just to let everybody know that we monitor everything. So we monitor the billing, we monitor the services. We also make sure that we monitor our hotline calls, and we take appropriate action if we find issues of fraud, waste, or abuse. We will work with the providers as best we can, but again, one of our core functions is to make sure that we don't have fraud, waste, and abuse in the program, and especially in this case, in this space, abuse. We want to make sure that recipients are not being abused in facilities. We want to make sure they're not being abused going back and forth from their homes when they're being transported back and forth. So that's something that we really, really take seriously. Okay, I'm now going to turn this over to Yvonne Jordan, who is with WellPoint, and thank you very much.
Thanks, Tracy. Good morning, everyone. I will be going over a brief overview of fraud, waste, and abuse. Fraud is an intentional deception that results in unauthorized benefits to oneself. These acts are not committed by accident or mistake. Waste is not usually considered a criminal act, but more so a legal violation for civil purposes and can result in a recovery of an overpayment, debarment from the Medicaid program, and other penalties. Abuse is when a provider's practices are inconsistent with proper, sound fiscal, business, professional, or service delivery practices. The result of these practices is usually unnecessary costs or improper payment by Medicaid. In some instances, the reimbursement for these services are unnecessary, not documented, or authorized. Here we have some examples of fraud, waste, and abuse. For fraud, there's billing for services not rendered, billing services for a member while they are in an inpatient facility elsewhere, and using transportation time as time spent on site. Examples of waste are overutilization, misuse of resources, overuse of supplies, and billing for medically unnecessary services. An example of abuse is billing services that exceed the prior authorized approved amount of services. And to reiterate the previous slide, the difference between fraud and abuse is the intent that comes with fraud. In some instances, business practices that result in waste and abuse can rise to the level of fraud. Some examples of these are providing services without proper authorization, except of course in emergent care, using unlicensed, unqualified, or untrained staff, inaccurate or incomplete documentation, billing for unsubstantiated services, and insufficient internal checks and balances. There are several consequences when it comes to fraud, waste, and abuse, including civil judgments and liens, exclusion from the Medicaid and Medicare programs, referral for criminal prosecution, restitution, and additional penalties on top of repaying Medicaid overpayments. I will now pass this off to Kia O'Neill, who'll discuss actions, ineligible providers, self-disclosures, and third-party liability. Thank you.
Thank you. Good morning. Next slide, please. MFD recovery actions. When an overpayment is identified as a result of an audit or investigation, MFD initiates actions for recoupment of the improperly paid funds, which may include sending a notice of overpayment, a notice of intent, and a notice of claim. MFD may add penalties, including false claim penalties per claim. MFD may also seek to withhold future Medicaid payments until the overpayment is satisfied, and may also file a certificate of debt on real estate property owned by a provider or an owner of a business. Ineligible providers. An ineligible provider is someone who is excluded from participation in federal or state-funded healthcare programs. This includes anyone who is debarred, disqualified, suspended, or excluded. Please remember that any products or services that an ineligible provider directly or indirectly furnishes, orders, directs, manages, or prescribes in whole or in part are not eligible for payment under those programs. Providers are required to perform ineligible provider checks upon hire and monthly thereafter. And all of this information can be found in the NJMMIS newsletter Volume 33, Number 2. Providers are required to check these databases on a monthly basis. And you must check not only for prospective employees, regular or temporary, but also current employees that are regular or temporary, and contractors or subcontractors. Self-disclosures. Providers who find problems within their own organizations must reveal those issues to MFD and return inappropriate payments. The link that you see, the first link, provides information on when and how to self-disclose Medicaid waste, fraud, and abuse. The Affordable Care Act and the New Jersey Administrative Code require that any overpayments from Medicaid and/or Medicare must be returned within 60 days of identifying that they have been improperly received. And there are several benefits to self-disclosure, and one of them is that providers who follow the protocols for a proper self-disclosure can avoid imposition of penalties. MFD's disclosure form can be found at the link on this slide. The self-disclosure protocol. So once a provider determines a self-disclosure is warranted, an initial report must be prepared and include this information. So it's a summary of the identified issue or issues, including the underlying cause, the Medicaid program rules potentially implicated, the nature and extent of any investigation or audit conducted to identify and determine the amount of overpayment, all corrective actions taken, an Excel file including a detailed list of claims paid that comprise the overpayments, an attestation of accuracy and completeness, and the name and contact information of the individual making the report on behalf of the provider. Self-disclosure, statistical sampling, and extrapolation. So if the self-disclosure involves statistical sampling and extrapolation to determine the overpayment, the provider must prepare a report of its findings. The work must be performed by qualified personnel, and you must provide an Excel file containing, at a minimum, the sampling plan, the universe sampling frame, the sample with the results of the sample review. That is, for each claim, indicate if it is an error, explain what the error is, and explain how much money should have been paid or how much money was overpaid. You must also include the random numbers that were used to select the random sample and the seed number, the extrapolation methodology and the output, and an explanation or description of all software used to perform the sample and extrapolation. So if you do choose to use sampling and extrapolation to determine the self-disclosure overpayment, this is a list of resources from the Office of Inspector General and CMS. So third-party liability, which is commonly referred to as TPL. Third-party liability exists when any entity or party is or may be liable to pay all or part of the cost of medical assistance payable by the Medicaid program. So examples would be Medicare, commercial health insurance, or TRICARE. TPL ensures that for federal and state Medicaid guidelines, Medicaid is the payer of last resort. All TPL shall, if available, be used first and to the fullest extent to pay claims before Medicaid, New Jersey Family Care, pays for the care of the Medicaid recipient. Remember that it is a violation of the Federal Social Security Act to refuse to furnish covered services to any Medicaid beneficiary because of a third party's potential liability to pay for services. And this slide also provides the phone numbers to the TPL hotline. And now I will turn the presentation over to Ryan Thuman. Thank you.
Thank you. Good morning, everybody. Yep, Ryan Thuman here with Fidelis Care, formerly WellCare, and I will be reviewing, case examples of red flags in adult medical daycare provider billing. Red flag areas, OSC released a report titled Adult Medical Daycare Providers Improperly Billed New Jersey Medicaid on 10/31/23, which identify the following findings. On the left-hand side, you're going to see the issues, and on the right-hand side, you're going to see the code violations for the New Jersey administrative codes. The first issue that we've seen was billing for services provided to beneficiaries who were also inpatient at a facility. The second issue that we found was billing in excess of 5 days of service in a week for an individual beneficiary. And then the last one we saw was billing for services for the same day, same service, and same beneficiary as another adult day health services. And again, you can see the code violation on the right-hand side for each of those billing issues. Next slide. One of the examples, again, for the first example, adult medical daycare bill for services provided to beneficiaries who are also inpatient at a facility. What we found is some examples for our data analytics identified the provider was billing for adult day health services despite the patient being confined to an inpatient facility during the time the services were supposedly provided. We saw discrepancies between admission and discharge dates were identified. Patients receiving ADH on days, they were either fully or partially hospitalized. And then we found billing records show that the services provided on days when the beneficiaries were only in the hospital for part of the day, and that raised concerns about legitimacy of these claims. Lastly, and then in 2021, Fidelis Care, again, formerly WellCare, we conducted an overlap project for members were being received adult day healthcare services while being an inpatient facility. This slide, what we're seeing is just an example of claims. If you look on the third column, again, as regards to recipient, we have 7 different recipients. And then we have the adult medical daycare service dates. So let's say for the first line, recipient 1, just as an example, the service date was for 10/13/21, and the hospital service date was from 10/12/21 to 10/16. So again, 10/13 was the claim date of when the adult medical daycare provider billed, and the inpatient for the hospital was 10/12 through 10/16. And the recovery amount for that recipient was at $86.10. And then again, you can see the 7 examples that we have for this while the member was inpatient, but the adult medical daycare provider billed during that inpatient stay. Example 2 that we saw, adult medical daycare billed in excess of 5 days of service in a week for an individual beneficiary. Again, our policy for the NJAC is we can only bill 5 days of service in a reversible within a calendar week. So again, from week Sunday through Saturday. We also found from our data analytics reveal that this one of the providers consistently billed for 6 consecutive days. Just want to note that 6 consecutive days, which exceeds the allowable limit. Next slide, please. This slide, what we're looking at again is kind of in regards to the 6 consecutive days. On column 2 for the recipient, we have 2 specific examples for our recipients. What we're looking at here for day of week of service date, we have from Monday for recipient 1, Monday through Saturday. And on the second last column, recoverable date would be the 6th day, which would be that Saturday. For recipient 1, which would be a total of $73.50. And then for recipient 2, you can see from Sunday through Friday, and a recovery day, we could recover on that Friday for that 6th day, $86.10. Next slide, please. Example 3, our last one for adult medical daycare, bill for services for the same day, same service, and same beneficiary as another adult medical daycare provider. And again, that's in a violation of the NJAC. You can see the code there. What we revealed is provider again was billing for the same day, and this is a direct violation of the Medicaid policy, which prohibits 2 providers from billing for identical services for the same patient on the same day. And again, we flagged this for duplicate billing patterns and then also raising concerns about potential fraudulent activity. And I will be passing this on to Michael Rosati. Thank you.
Thank you, Ryan, and good morning, everybody. So I am going to be talking with you about my office, the Medicaid Fraud Control Unit. Medicaid fraud is a serious crime. In addition to the civil and regulatory penalties that an offending provider may face, there are also several state criminal laws that are commonly offended by acts of fraud. So the Medicaid Fraud Control Unit, sometimes referred to as the MFCU or the MFUCU, is located within the Office of the Insurance Fraud Prosecutor, and it is the criminal oversight entity for our state. If you think back all the way or look back all the way to slide 10, the org chart that was put up, you'll see that our office is actually part of the Department of Law and Public Safety. And Medicaid fraud is such a serious crime because, as talked about throughout this presentation, there's significant impacts and consequences for the program. This wastes public funds, directing that or diverting them from places where they're actually needed. It erodes confidence in the program, and it can also eventually lead to negative outcomes and patient harm. So the Medicaid Fraud Control Unit is tasked with investigating and prosecuting cases that relate to Medicaid fraud. We do this through attorneys, so deputy attorney generals, investigators, both civil and then criminal investigators, detectives like myself. We also have nurses, auditors, and other support staff that help to police the Medicaid system. So our office investigates and prosecutes alleged criminal actions. There's kind of a wide variety of cases that we will handle. So these include allegations of physical abuse to beneficiaries, allegations including healthcare providers who are suspected of defrauding the Medicaid program, fraudulent activities by providers against the program, fraud in the administration of the program, and fraud against other federally or state-funded healthcare programs where there is a Medicaid nexus or connection to Medicaid funds. So criminal healthcare claims fraud up top, that's the statute citation relating to criminal healthcare claims fraud. It is illegal to submit a false claim to the Medicaid program or an insurance company in order to be paid for healthcare services which were not received or provided. So this particular offense is punishable by up to 10 years in state prison. In addition to all other criminal penalties allowed by law, a violator may be subject to a fine of up to 5 times the amount of any false claim submitted. Suspension or debarment from a government-funded healthcare programs often comes with this offense, and there's also usually a forfeiture of professional license. Just some things to keep in mind. If you are a practitioner and hold any professional license, you only need to submit 1 false claim to be convicted under that statute. Willful ignorance of the truth or falsity of a claim is not a defense. And you can be found guilty of healthcare claims fraud even if your claims were not intentionally fraudulent. These cases do end up in the news. So this is actually a press release headline from a case that involved an adult medical daycare, which states that this provider was sentenced to state prison for healthcare claims fraud. In this particular case, which was investigated by our office and prosecuted by our office, the manager/director and client outreach coordinator engaged in a fraud scheme by which they submitted false claims to Medicaid for adult medical daycare services. These false claims were billed for services that were not actually rendered and also for services that were not medically necessary. These investigations are very detailed. They're often long and ongoing, and they have a lot of different components to them. We use every tool that's available to us. In this particular case, there was an undercover officer that was actually sent in to the facility. So yes, we do have access to officers who meet the criteria to appear as if they're a patient for one of these facilities. And in this particular case, the officer was able to collect really valuable inside information, which included admissions by the offender, real-time evidence collection of what was going on in the facility. And kind of uniquely here, he was even solicited by the defendant to not only be a patient of the facility when it wasn't necessary, he didn't actually have a need to be there, which was kind of emphasized by the fact that he offered him to work as a driver in addition to being a patient of the facility, and also offered him to pay him under the table to do some yard work for the facility, which again was really compelling evidence of his knowledge that this person did not need the services at the facility. This investigation also included physical surveillance of the facility itself, so monitoring coming and going of staff and beneficiaries or patients. And there was also a search warrant, which was executed at the facility, and subsequently the records that were seized were evidential in the case. So as far as outcomes and penalties, in this particular case, the defendant pled guilty to second-degree healthcare claims fraud. He admitted to the submission of false claims over a 4-year period. He was subsequently sentenced to 3 years in state prison. Also was issued an 8-year debarment from participation in any government-funded health insurance program. And he was ordered to pay $147,000 in fines and penalties. And not surprisingly, the related facility went out of business. So the bottom line, the simple takeaway from this is ignorance of the law excuses no one, and it is the provider's responsibility to know the laws that apply to their particular area of practice. And with that, I am done. So I believe I'm handing it back over to you, Melanie, for.
Yes. Yeah, so thank you, everyone, and thank you for those who have hung with us for this presentation. We did go a few minutes over. I'm going to breeze through a few quick things. We will be sharing the slides as well as the recording with all of you. This slide contains contact information if you do suspect a need to report fraud, waste, and abuse. If you have questions that you weren't able to get answered or you forgot to put in the Q&A, you can submit those to this email address. I do monitor this, and I will coordinate a response for you. And then lastly, before you go, we would like for you to do a quick feedback poll to just let us know your thoughts on today's presentation. So just take a few seconds to fill this out. And again, we really appreciate you sticking with us. Another great thank you to all of our presenters today. Appreciate the time and the work that you put into putting this together. And with that, I hope everyone enjoys the rest of your day, and thanks again.